Dr. Sanjay Kumar from Patna. He will enlighten us about diabetes and COPD, a new association. Thank you. Over to you, Doctor.
Very good evening. First, I would like to thank the scientific committee for allotting me very interesting topic. But as the allotted time is being reduced from 20 to 13, I will have to rush through my slides, so please bear with me. So all of us know that COPD is a progressive disease and it is very common. The gene, environment, and the time is the important factor in the causation of the disease. And it is almost 11.7% of the global population is being suffered from the COPD. And now it is the third leading cause worldwide. Not only the smokers are getting COPD, but in the low and middle income countries, even the non-smokers have a very high number of COPD patients. The different risk factors are basically the female, tobacco use, low BMI, and biomass exposure. All these lead to COPD causation, and that causes the mobility disability, and 5-year mortality rate is also very high. So in India, as per the global burden of the COPD, India ranks number 2 globally, and COPD is here the second largest cause of death in India. So far, so diabetes is concerned, suffice here to say that it is basically a metabolic disorder leading to hyperglycemia, either due to the insulin deficiency or resistance, and the symptoms are polyuria, polydipsia, weight loss, etc. All of us know, and the problem is again very high. So far, so the India is concerned, about 11.4% patients are diabetics, and 15.3% are pre-diabetics, as per the ICMR data. And not only that, worldwide the number of diabetes cases are increasing, and it is supposed to be about 11.3% prevalence in 2030 and 12.2% prevalence in 2045. And there is an intersection of COPD and diabetes. 16% of the COPD patients also have diabetes, and the coexistence of COPD and diabetes not only increases the morbidity, but hospitalization and healthcare costs are also increased. Why this happen? If you go through the molecular level of the disease production of these two diseases, you may find that a lot of pro-inflammatory cytokines and adipokines have common roles in the production of the disease, both in COPD and diabetes. Either it is CRP, TNF alpha, IL-1, IL-6, and so on and so forth. So it is the shared mechanism that lead to systemic inflammation and oxidative stress, leading to disease causation, progression, and tissue damage. And the hypoxia in the COPD also lead to insulin resistance, so worsening the glucose metabolism. So COPD and diabetes have almost a symbiotic relationship, helping the disease induction and disease progression in one way or another way. There are a lot of epidemiological data that gives the linking of COPD to diabetes, both in type 1 diabetes and type 2 diabetes. The literature published in 2022 shows that if we study the lung physiology in type 1 diabetic patient, it has been found that the total lung capacity, diffusing capacity of the lung to the carbon monoxide, pulmonary elastic recoil, and end expiratory lung volume all are decreased in type 1 diabetic patient. And the basic mechanism behind this is collagen glycation of the lung parenchyma and the alveolar microangiopathy. The possible mechanism is oxidative stress, systemic inflammation, and genomic sequential changing. All these lead to cellular apoptosis and the diabetes production leading to hyperglycemia, insulin resistance, further lead to glycation, glucotoxicity, and thus causing the airway injury. The linking to type 2 diabetes to COPD is also found, and it has been found that a population-based retrospective study from Italy demonstrates a higher prevalence of type 2 diabetes in COPD patients to the tune of 18.7% as compared to the general population, that is 10.5%. Not only that, A 10-year follow-up period of type 2 diabetes showed that the newly diagnosed in 19% of the patients, showing increased prevalence and incidence of the disease. And again, the possible mechanism is oxidative stress, genomic changes, and the systemic inflammation. Third part is the therapy. The therapy that is being done in cases of diabetes and in cases of COPD, they may have the impact on each other. The common drug in the diabetes, that metformin, all of us know have good role in the diabetes, but it has good role in the COPD also. In an animal-based study, it has been found that it reduced the inflammation in elastase-induced emphysema. Not only that, there is reduction in the lung infection that modifies glucose flow across the lung tissue and improves survival rates in the COPD patient. So, in cases of COPD and type 2 diabetes, metformin improves health, symptoms less hospitalization, less mortality, and so on and so forth. On the other hand, inhaled corticosteroid is being used as a triple DAC therapy in the COPD. It has detrimental role in the diabetes as it may increase the glucose level. And not only that, it has been found that there is increased risk of new onset type 2 diabetes to the tune of 34% increase in the rate of diabetes and increased rate of diabetes progression. Third drug that is being used in the diabetes is the thiazolidinedione. Of course, it is a very good drug so far so the diabetes is concerned, but it has also good results in COPD. It has been found that it is associated with reduced risk of COPD exacerbations. And AAT augmentation therapy, of course, it is a good role in the emphysema, but it has been found to have good role in type 1 diabetes. It reduces HbA1c level in adolescents in recently diagnosed type 1 diabetes. Recently, just published in August 2024, a Mendelian randomization study in COPD and type 2 diabetes, and the study involved a 2-sample Mendelian randomization analysis on COPD and type 2 diabetes mellitus, and some additional tests for heterogeneity and horizontal pleiotropy were performed. The 26 independent single nucleotides polymorphism with a strong association to COPD were chosen as instrumental variables, and the findings suggest a pronounced causal relationship between COPD and type 2 diabetes mellitus. Specifically, COPD emerges as a risk factor for type 2 diabetes mellitus with an odds ratio of 1.06 and a 95% confidence interval ranging from 1.01 to 1.11. So, the Mendelian randomization analysis underscores a significant causal relationship between COPD and type 2 diabetes mellitus, highlighting COPD as a prominent risk factor for type 2 diabetes mellitus. So, in nutshell, the systemic inflammation in COPD lead to pancreatic B-cell dysfunction, to over diabetes, again leading to systemic inflammation, and ultimately decreasing the DLCO and respiratory muscle dysfunction. So, it is a vicious cycle affecting each other. Coming to the clinical implication of coexisting COPD and diabetes, there is high mortality and hospitalization, increased cardiovascular risks, and diabetes accelerate lung function decline in COPD. So, hyperglycemia increases risk of pulmonary infection, diabetes worsens COPD exacerbation and recovery, and increased hospitalization risk and longer hospital stay. So, what we need? We need an integrated care approach with pulmonologists, endocrinologists, and primary care physicians. Lifestyle modification, smoking, cessation, balanced diet, and physical activity has beneficial role in both, and we will have to do the medication management to balance COPD and diabetes control. More clinical trials on the dual COPD and diabetes management is needed, and there are some studies on the novel anti-inflammatory agents under investigations. The monoclonal antibodies in COPD, GLP receptor antagonist, and SGLT2 inhibitors, all being studied for their anti-inflammatory actions also that may help in the COPD and diabetes together. So, in nutshell, the COPD and metabolic syndrome and diabetes mellitus are common and underdiagnosed medical condition. COPD may be considered as a novel risk factor for new onset type 2 diabetes mellitus. Pathophysiology-wise, this is likely to be very complex with several factors being involved, including inflammation, oxidative stress, administration of glucocorticosteroid, COPD, related skeletal muscle dysfunction, and abnormalities in adipokine metabolism. On the other hand, diabetes may act as an independent factor negatively affecting lung structure and function, and diabetes can cause muscle and neuronal damage, which is relevant to the deficient function of respiratory muscles. And diabetes is independently associated with lower physical performance, which can be disabling for patients with COPD who already have some limitation in physical performance. Diabetes mellitus is able to determinantly affect alveolar capillary membrane and decrease DLCO, similarly to other microangiopathic complications such as diabetic nephropathy. Furthermore, diabetes mellitus is associated with presence of glucose in the airway secretion, and this may contribute to the increased risk of pulmonary infections seen in diabetics. Metabolic syndrome can increase the risk of COPD exacerbations, and diabetes is associated with worsened outcome of COPD flares. So I end here. Thank you for hearing the beating retreat talk of today's RSSDI function. Thank you.
Thank you, sir. It was really very nice and informative presentation. And good part is that you are well within your time.
Thank you.
Because we are already running short of time, so question and answer part can be escaped.